Welcome to Eye Contact. I'm Anders Behndig. Inevitably, a cataract surgeon does not end up with a happy pseudophakic patient 100% of the time. Today we're talking with Rudy Nuijts about how to address the needs of the unhappy pseudophakic. What are the most common causes of patient dissatisfaction, is your impression?
It depends a little bit, Anders, on which group of pseudophakic patients you are talking, of course. We have our regular monofocal patients. We have our monofocal toric patients. And then, of course, we have the group with the presbyopia correcting lenses, multifocals, extended depth of focus lenses, and so on. And I think it makes quite a difference what we're talking about. So I would say for the, let's say, regular monofocal patients, the causes that really relate to dissatisfaction are ametropia, being off target, and dysphotopsia. And that's an underestimated category, I think, dysphotopsia. We really have patients around that have positive and negative dysphotopsia. As you know, positive dysphotopsia are the patients that are really hampered by glare halos and so on. But the category of negative dysphotopsia actually is quite large. So we did some studies to look into that, and that's a figure that's within 10 to 15%, much more than most of our colleagues think of, actually. We also know that roughly a third to 50% of these complaints will disappear after a year. So our policy in that respect is usually that we wait for a year, see what happens, and if that's still the case, we discuss the options that we have. And one of the options there is placing an extra lens in the eye, which works a little bit like a diffuser of a zero correction. And in roughly 2/3 of the cases, that's beneficial to the patient, so the symptoms diminish or disappear. It's also, I think, nice to say here that we, as ESCRS, in our research committee, as you know, we are sponsoring a grant, actually, or sponsoring a study project that is looking into this etiology of dysphotopsia, and I won't explain here, but I think we are making steps there to see which one of the different pathogenetic ideas that are out there are really going to apply from within the data that we have from that particular study, where they are looking at the anatomy of the eye, ray tracing, using a very high resolution MRI technology. So that will be interesting, and actually will be also explained in a clinical research symposium here tomorrow. So that's dysphotopsia. Ametropia, I think is an easier thing to correct, and depends on where you are after the implantation. You can do an exchange of an IOL. Some people think that's really difficult to do that. I think that if you are a little bit used and familiar with it, it's not so difficult. You have to know a couple of tricks depending on the lens and the adhesions in the back. But that's an option, and otherwise you can do, of course, also, well, if the patient is happy with additional glasses, you're fine. Otherwise you can do refractive surgery to correct that. Okay, so with regard to toric monofocals, which is another group, I think there the question of the residual astigmatism comes in. And we have several factors that can explain that, you know, misalignment, increased surgically induced astigmatism also, or an error in the measurements before surgery. And you have to figure out which one of these is really the cause for it. If it's a misalignment, you can reposition the lens, of course. And if it's a spherical and cylindric error, you have to exchange the lens. And also in this case, sometimes probably you can apply excimer laser technology. It really does work in patients also with toric IOLs. Yeah. So those are the options there in that particular case.
Yeah. We've all had patients with the 2020 results who are still unhappy. What can we do for this, do you think?
Yeah, so it's when it's 2020 in the case of a regular monofocal IOL, I have alluded to that. That can be the cases with dysphotopsia, of course, so we don't have to touch upon that again. But when we have the presbyopia correcting IOLs, so the multifocals and the extended depth of focal IOLs, we are aware that can happen, and that may be related to contrast sensitivity loss. The patients that complain about waxy vision while still seeing 20/20. And actually we studied that in the past, some years ago already, when we were talking about the bifocal multifocal IOLs, and there it was clear, and I think it hasn't changed for trifocal IOLs. There it was clear that the primary factor for dissatisfaction there was residual ametropia. So you have to try with glasses if that could change. Well, in the 2020 it's not going to change, of course, because that's already solved. And then the second factor there was photopic symptoms and contrast sensitivity loss. Photopic symptoms is very difficult to treat, I think, in patients with multifocal IOLs. In my hands, using pharmacological measures like constricting pupils for a certain time and so on is not going to make any difference, actually, in most of the cases. So then you're left actually with more drastic measures, and that's exchange of the lens for monofocal IOLs. And there are studies around, and also it's my personal experience, that gives you a very good resolution of symptoms in these patients. They can become from very unhappy to significantly happy, despite the fact that you take away the near ad. So I think that people sometimes they sometimes wait too long before they bring this discussion into the equation with the patient, actually. And one of my rules in the process of counseling is always bring this worst case scenario on the table.
Yeah, that's a good idea. Yeah. What have we learned about patient selection and the pre-op workup that might help avoid some of these issues?
Well, the buzzwords there, of course, are always under-promise and over-deliver what people say. I think, although it sounds very familiar and kind of cynical, but I think it's really true. You have to be honest to the patient, what you tell them, and don't promise things that you cannot, deliver.
Yeah.
That's very important. And you have to come up with these potential side effects, like contrast sensitivity loss, boxy vision, glare, halos. There is not a single lens out there that had, in my experience yet, that doesn't have these problems. And the significant problem in patients with presbyopic correcting lenses, if you're talking about the multifocals and so on, is that in the individual case, you cannot predict the patient that will be without or with problems afterwards. We all know
that's kind of frustrating, isn't it?
It's very frustrating, and I think that at least in our country, in the Netherlands, has been the limiting factor for the pickup of presbyopia correcting lenses in the population, because it's still very small. It's not higher than 2%, actually.
I think it's the same in Sweden too.
Yeah.
Essentially.
And that's the driving force actually behind that hesitation of a lot of persons. And I think if you know of a communication manner with the patient that he is willing to accept the exchange option, it becomes easier. But I think that many people don't want to put that immediately on the table, because that would withhold patients sometimes or distract them from putting these lenses in their eyes. But this has to be communicated with the patient.
Yeah. What can we do better, do you think, in terms of preparing patients in advance to have reasonable expectations of the surgery? You talked about honesty and
Well, it's of course delivering the true picture of what they might expect, including the side effects, but it's also the things that we need to do. We have to look at the corneal topography if there is no hidden, irregularity or form fruit keratoconus. We have to rule out the patients that have comorbidity because of glaucoma and macular degeneration, or Fuchs endothelial dystrophy, although that's probably a shifting indication because of our DMAC results and so on that we have nowadays. But comorbidity and multifocals is not a very happy marriage, so I wouldn't do that. And we have to, of course, use the good lens formulas, A constants, all the regular things, topography, and dry eye, of course. If you have patients with dry eye, I think you have to be very, very cautious by offering this technology, because dry eye can also significantly deteriorate after cataract surgery because of a little bit of neuropathy that we induce actually by the incision.
That's true. What is happening on the technical front that might improve outcomes with multifocals and torics?
So if we look at what is happening on the toric front there, I think we have seen some advances in toric lens technology, where some of the companies now are incorporating technology where the lens is more tolerant to misalignment, actually. We have seen that, and that seems to work. We also have seen that the digital marking systems actually work pretty well in the sense that we are able to decrease the misalignment, but it does not transfer to better outcomes. So the patient is not a better uncorrected vision or less residual astigmatism from what we've shown, and also Oliver Findel's groups has shown, actually. What we do know, we learn also from what we do, actually, is that in the hours after the implantation, toric IOLs can shift. So there are some colleagues around who now prefer to have the patient lay down for a couple of hours after the implantation, with the idea that the lens then probably is more unfolded and more stable and fixed already in the back. And we have to see if this is a good advice, if we want to accept that in our patient flow, actually, because that will has some consequences, of course, for the flow. Multifocal IOLs, well, we have seen the advances, of course, but that's already longer ago, of the trifocal IOLs, which really give us a better intermediate vision. We have the extended depth of focus lenses, which work a little bit differently. But in some of these models, there is also diffraction, let's say, component, which gives rise to glare and halos. And we have actually compared a trifocal with a extended depth of focal IOL and only found a slight difference in the better intermediate vision with the EDOF lens, not in the side effects, actually. That were basically were the same. And in general, we know that EDOF lenses have a, let's say, slightly worse near vision because they are not intended to improve the near vision as compared to trifocal lenses. And I think we will see some changes there. The company's playing around with the light energy and so on. We have a new group of lenses now, monofocal lenses that are probably modified in the center through spherical aberration or more power. And the idea there that they will give us a better intermediate or a little bit of intermediate while taking a little bit back of the distance vision, which the patient wouldn't notice, but they would have no optical complaints. I don't have a very large experience with that at the moment, so we have to wait and see if that's really the way that we would like to proceed.
Thank you for joining us. For more information, please visit us at eurotimes.org.